This program is a combination of work between a collaboration between the internal medicine section and the family medicine section, and we appreciate all of you for attending this. The program is also sponsored by Merck. We thank him for their support. Moving on, our next speaker is Dr. Ebenezer Nyenwe. He's an associate professor of medicine, Division of Endocrinology, Diabetes, and Metabolism, College of Medicine at the University of Tennessee Health Sciences Center in Memphis, Tennessee. He's going to be talking about choosing anti-glycemic agents in patients with concomitant renal disease, current and emerging data. Dr. Nyenwe.
Good evening, everyone, and thanks for having me. Here is a pretest. "65-year-old male, history of cardiovascular disease and type 2 diabetes. Presents for evaluation. His BMI is 27, A1C 7.7, and metabolic panel shows elevated creatinine level with GFR of 50 mils per minute. What is the best choice of anti-hyperglycemic therapy for these patients?" You want them to choose an answer now? It's not advancing, or?
There we go.
Oh, you did? Okay. It wasn't showing the timing. Okay. Next question. 56-year-old female, history of cardiovascular disease and type 2 diabetes, presents for evaluation. Physical exam is unremarkable except for BMI of 27, A1C 7.7. Complete metabolic panel this time is no, this is the same question.
They'll do better.
Something is not right. Okay.
Let's go pre.
Oh, boy. Anyway, that question was supposed to be, no, it's no point. It's supposed to be someone who did not have any renal impairment and no cardiovascular risk factors. Okay, let's go. Here are my disclosures. The objectives of this talk will be, one, to highlight the epidemiology of renal disease in patients with diabetes, and also present the evidence that supports the renal protective effect of some anti-glycemic agents. And lastly, we shall look at the rationale for choosing one anti-hyperglycemic agent over the other in people with diabetic nephropathy. Now, we do know that diabetes is quite prevalent, and it's also a major driver of kidney disease worldwide. Over 400 million people estimated to have type 2 diabetes, and 30 to 40% of those would also develop kidney disease. And we do know that mortality in people with diabetes and kidney disease is also high and continues to rise around the world. In the United States, diabetes is a leading cause of kidney failure, above glomerulonephritis and also hypertension. And so agents that would reduce kidney disease, especially in people with diabetes, are quite desirable. Apart from high morbidity and mortality, we do know that people with diabetes kidney disease tend to die earlier, with about 16 years reduced from life expectancy compared to reference population. Now, what I'm going to say now is already been highlighted by the eminent speakers that came before me, and so they made it very easy for me. They've been trailblazers. But I read what is there anyway. Say, for patients with type 2 diabetes and chronic kidney disease, consider use of sodium glucose cotransporter 2 inhibitors, SGLT2, or GLP-1 receptor agonists, shown to reduce risk of chronic kidney disease progression, cardiovascular events, or both. And here is the algorithm which has been dealt with very wonderfully. I shall not belabor this. only to reinforce the fact that in people that already have cardiovascular disease or kidney disease, there are some agents that have been shown to reduce morbidity and mortality in people with diabetes. Now, again, this slide has been dealt with as well. FDA mandated that drugs being developed for treatment of people with type 2 diabetes should show that they are safe in terms of cardiovascular disease. And since 2008, several of these studies have been conducted and published. However, the primary endpoint for these studies was cardiovascular, namely cardiovascular death, non-fatal MI, or non-fatal stroke. Most of them did not include people, specifically people with kidney disease, although as secondary or exploratory outcome, they looked at kidney disease in those patients, which showed some benefit. But we'll keep in mind that those were primarily cardiovascular studies. Now, in this slide, we summarized 3 of those studies, cardiovascular studies that looked at renal endpoint as exploratory endpoints, if you will. The EMPEROR study looked at empagliflozin. Canvas study looked at canagliflozin, and the CLARE studied dapagliflozin. Now, in a meta-analysis published this year in the Lancet, the pooled population of over 34,000 people, average age was about over 60 years. Average age was above 60 years, and keep in mind that majority of those patients already had cardiovascular disease, and less than, 25% or less of those people had renal disease. Okay. However, the meta-analysis showed that whether those individuals had cardiovascular disease or not, they all benefited from SGLT2 inhibitors, the 3 agents we talked about. For empagliflozin, in the EMPEROR study, Canvas using canagliflozin, and also the study that looked at dapagliflozin. Pooled data showed up about 45% reduction in progression of kidney disease to end-stage kidney disease or incident albuminuria. Now, they looked at composite endpoint of progressive kidney disease, albuminuria. Put together, there was 45% relative reduction in people who had taken any of these agents, 3 agents we talked about, compared to those who did not. And they also stratified their population to those who had cardiovascular disease and those who did not. The effect was the same, about 45% reduction in risk for composite renal events. Now, they went on to look at different strata of GFR, those that had GFR less than 60, those that had GFR between 60 and 90, and those whose GFR was greater than 90. Again, the effect remained the same, all of them. Everybody benefited. If you look at the pool data in the forest plot here, you can see that everyone, the line is to the left, which favors canagliflozin. And relative risk reduction is somewhere around 30% to as high as maybe 44% in one of those studies. Now, this graph, the slide here shows the result for the EMPEROR study, the empagliflozin from the EMPEROR study. What we see, I show this slide because there's something interesting that also appeared in another study. Now, with commencement of the agent, you can see a drop in the GFR, slight reduction in GFR. But over the months, patients who were treated with empagliflozin remained stable, whereas it had continued decline. Right now, patients who were treated with empagliflozin remained stable after the initial drop in GFR, whereas those who were randomized to placebo continued to decline over the years. And we can see that somewhere around 52 weeks after the randomization, those who were treated with empagliflozin caught up and remained stable throughout the study. However, at the end of the study, they looked at when the study drugs had been discontinued, they looked at these patients again. And what you see is that those who were randomized to canagliflozin already went back to the eGFR they had at the commencement of the study. So that even this hit they took, if you will, in terms of GFR was not damaged, just that the mechanism of action of the drug. Now, we might look at that very briefly at the end of it. Whereas subjects who were randomized to placebo, the eGFR had dropped and did not improve even after the end of the study. Now, we shift gears a little bit to look at the GLP-1 receptor agonist. The data here is that of liraglutide from the LEADER study. And all we can surmise from this is that the composite outcome, which was progression of kidney disease or new onset albuminuria, was reduced in subjects who were treated with liraglutide. I think there's a graph that shows this better, right, in this graph. Now, the composite included new onset albuminuria, progression of kidney disease, or renal replacement therapy. But we see from this graph that the only one that reached significance was new onset albuminuria. All the other composites did not reach significance. And so the bulk of what we're seeing here is that liraglutide reduced new onset protein secretion, loss in urine, which of course we know is a driver for kidney disease. Now we see a similar data for semaglutide. Again, at about 16, for this is about 16 months after commencement of therapy. Now we see again that subjects who were randomized to semaglutide consistently had lower, were more protected rather in terms of loss of eGFR, relative reduction of about 46% compared to those who were randomized to placebo. And only last month, the REWIND study published their own findings. And what they did show also is that individuals who were randomized to dulaglutide also had relative risk reduction of about 33% compared to those who were randomized to placebo. And again, that protection was driven mainly by reduction of incident macroalbuminuria. The other endpoints, namely renal replacement therapy or progression of GFR did not reach significance. Again, the semaglutide, the REWIND study of dulaglutide shows that albuminuria was significantly less in those treated with the active agent compared to those who were treated with placebo. Even though both groups, continued to lose kidney function, it was worse in people who were treated with placebo, even though that did not reach statistical significance. And so overall, for SGLT2 and also for GLP-1, there appears to be some renal protection in people with type 2 diabetes treated with these agents. However, the data I've presented so far came from cardiovascular trial. These trials were not powered to answer the question, what will be the outcome in kidney function in people treated with these agents? Now, the CREDENCE trial was designed specifically to answer the question in people with type 2 diabetes and diabetic nephropathy. And in that study, they randomized about 4,400 subjects who had eGFR between 30 and less than 90 to either 100 milligrams of canagliflozin or placebo, and they followed them up for a median of about 2.6 years. And the study was discontinued prematurely because of incontrovertible evidence, unequivocal evidence that canagliflozin was beneficial. So there was no reason to continue to subject those who were on placebo to lack of benefit from that medication, if you will. And the primary outcome in the CREDENCE study trial were one, doubling of serum creatinine, end-stage kidney disease, renal death, renal or cardiovascular death. And when all those were looked at, you saw that individuals who were randomized to canagliflozin 100 milligrams daily had a 30% relative risk reduction in composite of doubling of serum creatinine, cardiovascular death, or renal death, or doubling of or end-stage kidney disease. Now, they also looked at just the renal outcome only, removing cardiovascular death, and the trend was still there. And then relative risk reduction was about 34% in that. The same for end-stage kidney disease, where the relative risk reduction was about 34% as well. And they went on to look at the trend in EGFR. Just like we saw with the empagliflozin, we see the same thing going on here. At about 12 months, you can see that initially subjects randomized to canagliflozin lost some GFR, but then they caught up at about 12 months, and they remained rather stable, whereas those randomized to placebo continued to lose kidney function, such that at the end of it all, subjects randomized to canagliflozin lost less than 2 mils per of GFR versus nearly 5 in subjects randomized to placebo, unequivocally demonstrating that canagliflozin slows down progression of kidney disease. Now, I did not mention that those in this study already had kidney disease. They already have albuminuria. The albumin creatinine ratio was 300 or more in those studies. Some had as much as 5,000 gross proteinuria, and yet we're seeing this kind of effect. Albuminuria reduced and stayed stable, whereas in people on the active arm, whereas placebo did not improve. And the major cardiovascular event, MACE, major composite of cardiovascular death, myocardial infarction or stroke, also was reduced by about 20% in those randomized to canagliflozin compared to placebo. And so also was heart failure, which was reduced by about about 39%, if you will, or 40%, compared to those randomized to placebo. And so we can say that in terms of safety, Dr. Garvin alluded to the fact that canagliflozin, in one of those, in the CANVAS study, there was some evidence of some signal of increased fracture and amputation, but that was not seen in this study. However, there was almost tenfold increase, about tenfold increase in the incidence of diabetic DKA compared to placebo. But the numbers were quite small, 2.2%, not huge. Now, we can say that canagliflozin use in patients with type 2 diabetes and albuminuria decreased the risk of renal-specific endpoints, and also was associated with a 34% reduction in progression to kidney failure. Now, these are people who were already taking ACE inhibitors or ARBs, angiotensin receptor blockers. The renal protective agents we know in people with diabetes are ACE inhibitors and ARBs. Now, addition of SGLT2, the SGLT2 canagliflozin resulted in the effects we've talked about, 34% relative reduction in CKD, and also 30% reduction composite of worsening kidney disease, renal replacement therapy, or cardiovascular death or renal death. I think that's all I have here. And well, mechanism, as Dr. Gavin said, we do not know. But one thing we know, we do not know for sure, but one thing we do know is that these agents reduce the filtration. They reduce reabsorption of sodium and glucose in the proximal tubule. Delivery of solids to the distal tubule, as it were, will stimulate the juxtaglomerular apparatus, which will feed back to the glomerulus to reduce filtration. We know that the major driver for diabetic kidney disease is hyperfiltration. If we reduce filtration, perhaps we might be able to reduce that. But this remains a subject of investigation, and I hope that we'll be wiser as time goes by. But these agents have shown some salutary effect, and if we're looking at people with kidney disease, proven kidney disease might be beneficial to add SGLT2 agents. I think that's all I have. I'll say thank you. I hope this works now. The same 65-year-old male, history of cardiovascular disease, type 2 diabetes, A1C 7.7, patient is overweight, eGFR of 50. What is the best choice of anti-hyperglycemic therapy in this patient? Okay, do we have a second one? Okay. All right, this comes out nice now. No, the same old question now. I guess it came out wrong. But it's supposed to be 56-year-old female, no cardiovascular risk factors, only obese, not on any agent already. What should be the agent? In other words, what should be the first line addition to lifestyle modification? Okay, yeah, I think I feel relieved now. Thank you.
Thank you, Dr. Nyenwe.